Hello, everyone, and welcome to the RSA series of webinars delivered by the Royal College of Surgeons of Edinburgh. Today's topic is about the principles of managing fractures. Whether in A&E, on the ward, on a football pitch, fracture management forms an important part of our work as doctors. It is easy, it is logical, as long as you understand the principles. We're privileged today to have Professor Lee to tell us all about it. Prof. Lee is an orthopedic consultant and a visiting professor of sports medicine at the University of Lincoln. He has a wealth of knowledge and experience in medical and surgical management of fractures and sport injuries. He has strong ethos for personalized medicine. Working with the British Orthopaedic Association, he has delivered many practical and instructional sessions to students and junior doctors. As a regional surgical advisor for the Royal College of Surgeons of Edinburgh, he continues to support education. You would be posting questions throughout the presentation through the Q&A tab. If you find that you want to ask similar question, then please just give a thumb up to the question and that will be bumped up and I will be putting that to Professor Lee at the end. Prof. Lee, all yours.
Thank you very much, Raymond. Thank you. So today we're going to talk about the principle of fracture management. So first of all, we want to find out what is the outcome of this webinar. It would be about, we understand the cause of the fracture, learn about the initial management, stabilization, and we're going to touch up on how fractures heal. I'm not going to go into all the biomechanics or biochemistry about how fracture healing works. But I want to give you a more clinical approach, a more personalized approach to each fracture. So more importantly, we need to learn how to make important decisions and how we can treat these fractures. So these are the principles of treating fractures. First of all, we must understand what is the cause of the fractures. We need to some of you might or might not have heard of something called ATLS, which is Advanced Trauma Life Support, which is something extremely important for managing any traumas. In the fractures, 90% of the time is due to a trauma. There are other causes for non-traumatic fractures. We need to look into that carefully. We will talk a little bit more about that. Then after we understand what causes this fracture, we can talk about how can we stabilize it. And then after that, we can start thinking about the PCP approach, which I'm going to touch upon and explore a lot during these lectures. And more importantly, how to manage this fracture. And also, we need to take in special considerations, such as during COVID-19, should we or will we manage fractures differently and how we could do that. So first of all, let's go back to what is a fracture. It is a very, very simple thing. A fracture is a break in the cortex of the bone. That's what defined by a dictionary. You may hear some of the patients say to you sometime that, doctor, is it a fracture or is it a break? It is something that we hear very common in fracture clinic or in A&E. They are the same thing. But however, we need to understand who we talk to. Sometimes when we're talking to a patient, we need to take our time to explain to them, and we may actually have to spell it out to the patient. Sometimes a fracture is a break in the bone. It is something that we need to be aware of. We need to understand. We need to be able to communicate to our patient well. Next thing is the causes of the fractures. Most of the time, cause of the fracture is from trauma. Nowadays, it can cause by a road traffic accident or sporting injury. This is the time that we need to use a surgical sieve to look over the common causes of fractures. But mainly, as I say, is trauma. Do not forget there are non-accidental injury exists in this world. These type of fracture is not just about managing the break of the bone itself. It's usually about managing the whole of the person and the social circumstances. It's extremely important. It is very sad, but it's extremely important for doctors to pick this up. And of course, we must not forget about medical reasons for fractures. There are many reasons. There are many metabolic disorders that can cause fractures, but the most common cause of fracture is remain to be trauma. So after we talk about trauma, we know about the causes of the fractures. We need to think about how do we stabilize it. So on this mannequin, this is a course that we were doing. There are courses that we can show how we can stabilize fractures. And commonly, what we want to do after we rule out what the cause is, we want to hold the fracture steady, whether that is with bandages, whether that is with a splint, with external fixator. There are many different ways that we can stabilize this fracture, as long as the patient is not moving or the fracture is not moving, and then we then can start thinking about the next step of how we manage it. So in terms of, after we talk about the cause and the stabilization of the fracture, we then want to think about how does fracture heal. So this is basically what we talk about, the management of fractures. There are two ways the fractures can heal according to the textbook. So one is what we call primary healing. The other one is called secondary bone healing. So the way that we think about it is primary bone healing is kind of like we are tricking the body how the bone is healed. So we can go into very, very much detail into it if we want to. We can talk about the cutting cone effect by the osteoclast and how the bone can continue to heal. But essentially, what primary bone healing is mean that we put the bone back together, hold it so tightly, the body think that as if the bone is not broken. So therefore, it continues to trying to form that bridge. As opposed to secondary bone healing, which has got this process in there. So this is what you read about fracture healing process, such as the hematoma formation, fibrocartilagens, callus formation, bone callus formation, and bone remodeling. Essentially, on a secondary bone healing, it's pretty much similar to how things heal with secondary intention, with the form of hematoma and the bone start remodel around it. So basically, in the body, there's two main types of fracture healing. So these are the principles. We need to think about which way that we want the body to heal in order for us to manage this fracture appropriately. Both method is as good, or if there's no one better than the other, it all depends on the circumstances, what the fracture is, and how we're going to, what the patient's needs are. It is all about the biology. If there is cells around the fractures, around the body, around the injury, there is good blood supply. If the fracture is stable enough, if we give it enough time, all fracture should heal. Now, of course, if there is many factors, these four factors is very important. For example, if we sometimes have a very big road traffic accident with high energy injury or even gunshot wound, a lot of the time the cells around the fracture site might be dead. So therefore, we can't really expect that the bone will heal or the bone will form. And of course, if there's no blood supply to the area, nothing will grow, nothing can heal. The one thing more to think about in terms of fracture management is about the stability. Now we can dive very deep into the stability there. In orthopedics, we can actually measure how stable something is, and depends how stable something is, either primary or secondary bone healing will occur, or even secondary bone healing doesn't occur if things are not stabilized enough. It just becomes a fibrocartilage or fibrous union. But essentially, in order for bone to form, we want things to be stable in a longer period of time. But I'm not going to go into detail about the biology today in terms of the biochemistry of how things work. But all we need to remember is it is all about the biology. So we were talking about earlier on about the PCP principle. So this is, first of all, personalized. When we're managing a fracture, the first thing we need to, after we deal with the initial insult and the cause, initial stabilization, we then need to start thinking about how we can treat this fracture. Treating the fracture is not just treating the x-ray, it's all about treating the patient as a whole. So first of all, we need to know who is this fracture belongs to. This fracture belongs to a person. We need to know how old they are, which side is, of course, and when does it happen. And do they actually have any associated risk factors? Remember I say about the biology. So we want to think about, is the patient's biology compromised? Is their vascularity compromised? We need to think about what that person is like and how the biology responds in order to tailor a fracture management technique to that person. So that's extremely important. Then after that, after we think about the person, after we understand the past medical history of the person, we want to think about the character. Now, the character is the character of the fracture, and this is the time that we want to look at the X-ray. Is this fracture an open fracture, a closed fracture? And of course, we want to make the other word is stable or unstable. that is open to interpretation. There's many different people argue what is stable, what is unstable. But essentially, the stability of a fracture means that can I actually maintain this fracture with whatever mean in that position? And that is a very basic of a definition of stability. Now, of course, we want to look at, is that involving the joint? If it involving a articular cartilage, the way that we're managing may be different because we want the joint to put back anatomically for patient to have full range of movement. And then we can get to the technicality about, we can describe X-ray, we can describe fractures. It could be a transverse fracture, oblique fracture, and all sort of acronyms that we can come up with, butterfly fragments, and all sort of things we can talk about. But essentially, what I talked about before, what I tried to put down is that orthopedics and fracture management is relatively simple. You can see the break on the X-ray if it's big enough. If something is so small that you can't see, you're querying in your head that is it a fracture, is it not a fracture? Either it's such a small fracture, it doesn't matter that much, or something that we want to speak to your senior about. Now, but the important thing is we need to understand the character of the fractures in order for us to deal with it. And the last thing about the PC principle is prioritize. So after we understand who is this fracture belongs to, what the fracture character is like, then we want to think about, is this something that we need to deal with right there, right now? So we want to look for is in the window of opportunity. If we talk about secondary bone healing, usually it takes about 6 weeks. If the fracture happened 6 weeks ago, looking at this X-ray, actually we probably have missed our window of opportunity to fix this fracture. So therefore, it's not such a high priority in that sense. Of course, the other effects we probably would have looked into about the vessel effects, about any skin that's causing pressure effect. And for example, the other thing about fracture is that if the patient is lying still, following a neck or femur fractures, they're not moving, they can contract chest infection and they can have pressure sores. And these sort of things need to be taken into account in terms of priorities. And of course, after that, we want to think about what resources do we have, what skill do we have, and do we actually have enough time to manage these patients? And as I talked about before, COVID-19 have changed a lot of things. Some of the fractures, traditionally, we would go to fix and do surgical intervention. Due to COVID-19, due to the potential risks of spreading the disease, spreading the virus, some of these fractures may actually be better off managed slightly differently with a conservative management or slightly different management to what we would do in a normal time. But the key is that we need to take account into all the resources or the available skill, available time before we can make a judgment of how we can manage these fractures. And all these should take into account into the principle of fracture management. So here we are. In terms of management, we can do it surgically or non-surgically. We could either managing it close, or we have to cut the skin open and find the bone, put them back together, and put paste and screw to fix it. We can either choose to operate immediately, or we can intervene with this fracture immediately, or we can choose to delay, depends on how the fracture grows. Sometimes we would choose to do delay management in fractures that with poor blood supply or very poor skin condition, or maybe even in children, sometimes we would want to wait. Perhaps the growth plate would actually modify and actually change things. So therefore, there's no one fixed rule of how to manage this fracture. And remember, we need to manage the patient, then manage the X-ray, then manage the expectation from either the family or the social circumstances. So I usually go for fracture management. In my principle is, first of all, look at the person, and then look at the character of the fracture, and then we need to prioritize of treatment. There are many different ways that we can manage these fracture. It ranges from what we call conservative management, or somebody can call it do nothing, to very, very invasive stuff with plate, with screws, with nails, with wires, or we can even replace the joint. And there are more exciting things coming along, such as with biologics to actually stimulate the bone growth and make things heal. There are many different options. However, every single one of these options can be possible to treat a fracture. However, when you put the person into it and you put the priority into it, the management change depends on, and there's no one specific way that we can treat the fracture. So in terms of treating a fracture, I got another principle I would like to share with you guys. It's very simple. When I was learning about fractures, they call it a broken chair principle. But nowadays, in the 21st century, it's more to the mobile phone. So it's what I call the crack screen principle. So when you have a crack screen, you can either leave it. So for any fracture, you can either leave it. We can try to fix it. We could replace it with joint replacement, or we can cut it out and bin it. These 4 options are possible to treat any fractures. Depends on, as I say, the PCP. But this are very, very important to consider. And especially the last P that I was talking about, during COVID-19, there may be, this will affect our judgment, this will affect the resources, and therefore fracture management could be slightly different. So all in all, in the summary, we're going to talk about what I want you guys to remember is when you see a fracture, first of all, you think about what causes this fracture. Is it a simple trip and fall, someone called mechanical fall, or somebody actually had a heart attack and then they fell and then broke the wrist? Because at that point, the more important thing you look at is someone's heart, not someone's wrist. Something that worth keep that in the back of your mind. Stabilization. How do we stabilize this fracture immediately? Sometimes we have to be creative, and there is the story with the ATLS, people being very creative initially, and then it developed into a discipline. Sometimes we just strapping up with a piece of stick to just stabilize the fractures. But of course, in secondary healthcare, if we don't do that, we use plaster, we use splint, we use traction. There's many different ways we can stabilize the fractures. And don't forget the PC brief principle, and always consider all 4 options of treating fractures. We can either leave it, we can fix it, we can replace it, or we can bin it. So after my summary of my lecture, I'm going to share with you a couple of my clinical cases that I would like, hopefully you guys could use the things that I just taught you and put some judgment into it. So this is case number 1. This is a 64 years old gentleman that had got a broken leg, and you can see the x-ray on there. This is the femur, and you can see it is shattered on there, and this is where the femur is. I just showed you on the picture there. So remember, what do we have learned? So we're going to put a poll on there, and I hope you guys to be able to tell me what is your thought about how we should manage these fractures. So first of course, we want to find out what causes it, how we're going to stabilize it, and the principle that we talked about. So this is I just try to make this case relatively simple, relatively easy, because it's the first case. So this patient tripped and fall completely well. Usually there's no other medical history, no skin compromise. So so that's what we're going to, so that's the cause. We talk about stabilization. So the patient do not have any active bleeding. The HB, the blood, all the markers are relatively reasonable. There's no other associated injury. Now, how we can stabilize this patient in terms of how do we stabilize this fracture? So can anybody think of any way? So we could try to strap something onto the leg. We can try to put traction on it. But actually, with these type of femur fracture, either we put traction if the skill set is there, if the availability is there. If not, immediate stabilization usually is bed rest and keep still. Now, looking at the PCP principle, this patient is a very poor diabetic, also got lymphedema and have relatively poor mobility, even before the patient had the fracture. The fracture is unstable because if you think about it, the leg is on the femur, and every time the patient moves, it would be very painful. It's almost impossible to stabilize it with external means. And it's very, very difficult to control because it's in 3 or 4 bits. Is it a priority? It's the next P. This patient have a very severe injury. Breaking a femur will give you a very large amount of blood loss, and also patient will be very painful and lying in bed. If patient lie in bed, as I mentioned before, patient can get a chest infection. They can develop a pressure sore relatively quickly, and it is not a great idea. And people would die with a slow, painful death with a chest infection. So it is a priority. It is a severe injury. So, but then we need to take into account right now of COVID-19. Does COVID-19 change our management right now, this moment? Actually, in this one, it may be not. So here's our poll that I would like to put up, and hopefully you should see that on your screen soon, about how we should manage this fracture. Remember, I say the crack screen principle. So after the information that I told you about this patient, what would you think that we should do for this gentleman? So we think about the PCP principle. Patient is a poor controlled type 2 diabetic, got lymphedema, multiple medical comorbidity. However, it also so the fracture characteristic is in multi-part, is very unstable, and in terms of the last P, and we decided it is a severe injury. It is a priority. So here we go. Hopefully everybody have the chance to make the call on the poll. Will we be able to put up the poll? What the answer is? So most of you would choose that we want to fix it now, and there are some people think that we leave it and we bin it. And okay. Now, so it is interesting. We want to fix it, and the question is how we're going to fix it. There is a more in-depth discussion in terms of how we could fix it. So this is, you can see, this is where the fracture was the one that couldn't quite make out on the X-ray before, is in multi-part. And for the one that got a very, very sharp eye, you can see this patient have severe osteoarthritis already in that hip. In terms of fixation, if you're going to fix this, either we could put a plate, put some screws in there, hold it together. We could put a rod in there to hold the bone together. There are many ways that we can think about fixation. We can then go on to the next discussion, if we wanted to, about how the biomechanics work, and will fixation slightly going to work, or is fixation actually going to fail because the patient actually also got a hip arthritis on the top of the hip. So my choice for that patient, yes, I didn't leave the patient. We fixed it. We replaced it. So we replaced the hip, and we have hold the fractures together, and we bypass the fracture in the same time. Patient got multiple medical comorbidity. The reason that I was putting that into account is that patient got type 2 diabetic, is type 2 diabetic, so therefore the blood supply is not that great. You got macrovascular disease and microvascular disease as well. So the Hole's factor is not that great. We would also consider that she also have lymphedema, and also looking at the X-ray, she got a very arthritic hip. So the chance, if we just fix it without replacing it, the chance for it to fail is very high. So this is why, on this specific occasion, using the PCP principle, that's the way that we manage this patient. I got one more case for you. This is a slightly simpler case. And it is relatively simple things that we see as well. So we commonly see hip fractures, and we commonly see wrist fractures as well. This is a 70-year-old lady with a broken left wrist. Again, relatively simple history, relatively simple story. Here is our X-ray. So here's a broken wrist, and how are we going to manage this patient? So remember our initial what we have learned, what causes it. So we have, and how do we can stabilize it initially? Use the PCP principle and the crack screen principle. So the cause of this patient basically have a fush. What is a fush? It's fall on outstretched hand. Very, very common. People fall, you put your hands out to save yourself, and then your body weight fall onto your hand, then you fracture your bone. And it is a very, very simple mechanical fall, no other cardiac history or no other head injury or anything like that. So we're happy with the cause. Can we stabilize this fracture immediately right there, right then? There's no active bleeding, there's a close injury, everything is reasonable, there's no other injury. So the choice for stabilization at that immediate period was to put in a back slab of a plaster to just stabilize the fracture. The more interesting part next is talking about the PCP principle. So this is the PCP principle, and remember, this is a left-handed injury. Okay, the patient is right-handed, but it was a left injured. Left hand is a retired maths teacher, and there's no other medical comorbidity with that patient. So that's our personality of the patient, and then the next is the character of the fracture. The fracture is shortened, and it's not that easy to control because it's shortened and it's angulated slightly. So that is a typical character of the fracture. I mean, we could argue that it's very easy to control with really beautifully well molded plaster, or we can say that actually it's really difficult. We need to put wires and plate in. That is a debate. The next thing is priority. Is this a priority right now to do something? Is this fracture life or limb threatening with a simple wrist fracture? No, it's not. Is it neurovascular compromise? No, it's not. So is it a high priority, as high as a priority as our broken hip? No, it's not. Now, on this specific occasion, did COVID-19 make any difference to us? And I think it does in this specific occasion. So same again, we're going to put the poll up and just want to ask you guys what we should do. Again, the crack screen principle, hopefully our poll is going up, what we can do and what we're going to do. Again, we can just leave the fracture as it is, and we could fix it with plate and screws. We can manipulate it slightly. We will use the manipulation bit and as leave it. We'll put it. We can pull it slightly and manipulate it slightly to put it in a slightly better position. But if you think that the fracture is not going to be, it's not that stable, it probably will slip back. Or so we replace it, give a wrist replacement, or we just chop it out and bin it and left someone without a wrist. So these are the possible options. Not all of them are correct, and they all have their place. And I hope you all had the chance to do the poll, and let's see what we got and what everybody think. Great. So most people are thinking that we should leave this fracture. I'm sure you have your reasons behind it, and I'm glad that replacement is only 1% and binning it is 3%. Very good. Now then, let me try to get the next slide. So discussion-wise, so yeah, as we can see, it is a wrist fracture. It is unstable. It is not that easy to control without any surgery, without any plate or wires in there. But actually, when you take the whole situation into account, it is a left-sided injury. Patient is right-handed, so it's not really causing the patient that much discomfort, that much trouble. And also, during COVID-19, do I really want to take this patient to theater to expose the patient's potential risks and actually use up the PPE for this type of fracture, and also the patient's own belief and own wish to take into account. This is the outcome. This is what we decided to do, and patient choose that he would think that the best way for him would be a fixation. It would be a plaster instead of any fixation. And with it, and then we will monitor this fracture, and if there is problem in the future, potentially we can do corrective osteotomy to correct this. So this is another way to deal with fractures. So one last time about the principle of fracture management. We need to understand the cause of the fracture. Please, please, please always have the non-accidental injury in the back of your mind and some medical causes, although most of the time it is fracture. We need to somehow think about initial stabilization. There are many different ways that we can do that. Remember PCP, the personality, the character of the fracture, and also the priority of time and resources. And finally, every single fracture, you can treat it 4 ways with the crack screen principle. And that's the end of my talk. Thank you very much. And that's my email address. If you've got any question, you can email me. But I will take some questions along with Layman as well afterwards. Thank you.
Paul, many thanks for this great lecture. The audience have enjoyed it, and they've got quite a few questions, which I've tried to answer as many as I could as we went along. But there's a few questions that I thought that the majority would benefit from an answer from yourself. So they wanted to know a little bit about what your understanding is of damage control orthopedics. They hear the terms of early total care and damage control orthopedics, so they're not quite sure about damage control orthopedics.
Sure. So that is basically for a more severe trauma that we're looking at in terms of damage control orthopedics. So what we tend to do is that we want to try to avoid something called the second hit phenomenon if we can. If someone have a massive severe injury, so in the initial aspect of the injury, they're taking a lot of reserve out of the body. And then afterward, if we do surgery on somebody immediately, there's another insult to the body. So with this double hit phenomenon to the patient, to the body, it will actually cause more damage than good. And sometimes what we need to do is this is why I stress about the stabilization part. And damage control orthopedic is pretty much at the stabilization part. We want to stabilize the person, we want to stabilize the fracture, and then we want to scan the patient, we want to plan, and then after that, in the optimal time, guided by markers, guided by biochemistry, then we find the optimum time to go back and intervene and fix those fractures. Not all fractures need to be fixed in the first instance. This is the part that we need to be very, very careful of, taking into account the person and also taking account into medical condition.
Thank you. The second question is, if a person has an open injury with a concomitant vascular injury, so what would the order be of restoring the leg? So would you fix the bone first? Would you repair the vessel? What would you do?
So I think the answer is it depends, but most of the time it's more important to tend to tap off first. So if someone have a vascular injury, they're actively bleeding, they doesn't matter how quickly, how much blood that we're going to give the patient, it will just leak back out. So we may as well just pour the blood on the floor. So first of all, we need to stop the bleeding first. So we need to deal with the vascular injury. We don't have to repair the vessel. We need to just stop the bleeding to start off, and then stabilize the fracture as well. And then it will be a combined case with the orthopedic surgeon and the vascular surgeons to potentially do a joint case together. And then I think it depends on the case. It's down to the discussion of, shall we revascularize and recannulate the limb first, or we want to have some sort of structural stability first sometimes before we bypass and give some time for the to salvage that limb. I think when we come to this type of massive injury and the and in terms of the vascular with orthopedic injury, I think both input is important. I think we should have both surgeons there. But the more important thing is we want to do damage control to start off.
Okay, and one last question. So you mentioned the four options for managing each and every fracture. One of the options that you put out there is bin it, and I've got a few people asking, what do you mean by bin it? So
bin it means excisional arthroplasty is one of them. So if there are sometimes there are fractures that is too comminuted, or there are infection within it, or for example, there is something that is really can cause further damage in the body. It's better off to remove that bone fragment and put it in the bin. And we may not, sometimes we have, but in some places in the body, we may not have a replacement part for it, but we will just have to leave it. Leave a gap in the body, and sometimes depends on where the fracture is, which site we're talking about. It is a very, very viable option.
Thank you very much, Professor Lee. Thanks, everyone.
Well, thank you.
Next week, we'll have another topic as part of the Regional Surgical Advisors series, and that is to do with the management of pneumothorax. So it'll be on Thursday, same time. We'll look forward to seeing you then.
Thank you all.
Thank you.